Hi, Dr. Shobeiri. Thank you so much for taking the time. I think this is one of the episodes I'm the most excited about. I put it out to my community in terms of what questions they wanted me to get covered, and I was flooded with responses. So you're a man that people are watching and very interested in terms of the work that you're doing, and I really, really am grateful for you sharing your time with me today. So thank you. I'm going to hand it over to you. If you can introduce yourself in terms of why so many people are paying attention to the work that you're doing, what you do for work, where you are in the world, and then I'm going to have some more specific questions for you.
Yeah, it's thank you so much, first of all, for having me. It's such an honor to be able to really address the patients and their questions. I realize that they are not getting the answers they need. So it's very meaningful to me to be given this opportunity. I really don't know why everybody is paying attention to me. I think you need to answer that question. I think each person has a different reason. I'm very passionate about my patients and what I do, and I think a lot of times patients just talk to each other, and they come to me for different reasons.
So you are based in, you said Washington, D.C. area, sort of Northern Virginia. Is that correct?
Correct. Yeah. So, and I think the next part of your question was to introduce myself and see who I am and what I do. Thank you. So if you're familiar with Washington, D.C., it's a really strange area with all these different states coming together. We're in Northern Virginia, a health system called INOVA health system that serves the Northern Virginia, so it's really Washington, D.C. capital region. And then what I do, I am the head of the gynecology program for our health system. So any minimally invasive surgery, urogynecology, so on and so forth, that's what I do. In terms of my background, I have been a urogynecologist for a long time. It seemed like feels like I was grandfathered into this. I was getting my training when there wasn't really much of a urogynecology track, and just as I was getting the training, they came with the making it official and making it a subspecialty by the American Board of OBGYN. But I was really passionate about the field mainly because, as a medical student, this was in 1990s when I walked into an operating room. It didn't seem like a single doctor actually owned the patient, like a OBGYN would come in and say, hey, I'm going to do a hysterectomy, and then a urologist would walk in and say, hey, I'm going to be doing a sling procedure, and like a colorectal surgeon would walk in. And I don't know, to me as a lowly, not very smart medical student, I thought it was like a zoo. I'm like, and I was thinking, it's vagina, it's not that big an area. We would really need 3-4 people to operate in the same area. So, and that was a shortcoming that I think the American Board of OBGYN also recognized, that you really didn't need to have 10 people operating on one small area. You just needed to get one person trained to take care of all that area. And then the other thing that really blew my mind, I think, as a resident, was just as a student, how much women were misunderstood, and as a resident, I was just blown away by how little was known about pelvic floor. Like the even the basics that you needed to know what a pelvic floor is, people didn't know or appreciate. So, and meanwhile, I was looking at doctors doing their surgery, and I was asking all these questions, like, why don't you do this? What about this? Do you understand the basics? What are the muscles? What are the fascia? What are these things? And really, there was a lot unknown. And me being a very curious person, first of all, just really connecting with women all together and being able to converse with them which was my natural area, was great. And was like, so this is the population I cared about. But then really nothing was known about the basic pelvic floor that they needed to understand. So make the long story short, I decided to do a fellowship. So for the audience who may not know, what it means is that you finish your 4 years of medical school, and then you do your internship and residency, which in my case was another 5 years of training in OBGYN and everything else. And then you do 3 years of fellowship training on top of that. So by the time I was done, it was like 17 years of higher education.
Wow.
But just being a very curious person, we had to do a thesis research in my fellowship, and I really wanted to understand the basic anatomy of pelvic floor and things that were not described. So my thesis project became so humongous that I actually didn't complete it for almost like 3-4 years after I finished my fellowship. And the reason it took so long was I just looked at the findings that I had, and I was looking at all this, and I was just trying to find out what's the basic anatomy of pelvic floor, where are the muscles, what innervates it, and really nothing that I had found was described in books or written anywhere. And I was looking at this and I'm saying, gee, I really think I may have done the dissections wrong. Maybe maybe this, maybe that. And then I read a paper from a German guy from like 180 years ago where he had described some of the same fibers that they had seen that nobody else had described. So, generally when you talk about pelvic floor, you're talking about the levator muscles, which generally they're very misunderstood. People think of levator muscles as muscles that connect to a bone, and that's what they are. They're just very complex. And I was looking at the muscle fibers that had not been described so far were like puboanalis, puboperinealis muscles I was thinking in my field. And then, so I did that. I showed all the number of muscle fibers that existed in a woman's pelvic floor. And this was really important because to simulate injury and create biomechanical models of injury and try to reproduce it on a computer, you need to know exactly how many numbers of muscles you have, what their properties are. So those were the kind of things that we used to create the models that if you see like animations of pelvic floor and childbirth, they have used basically a lot of the information that they created. And then also we looked at the innervation of the pelvic floor that wasn't described up to that point. So I think, I published this and everybody got up and said, who cares, why do we really need to know this information, and we're just doing our surgeries. And I was like, it's really important for you to know the basics of what you're working on. You just can't be doing stuff. And I was like, okay, great. I spent like 6 years doing this. How am I going to, like if Kim comes to me, I cannot dissect her and look at her muscles and say, this is your puboperinealis muscle and this is your levator and muscle. Like, how can I see them? And they had, MRI was available back then, but very much it was, the pictures were still fuzzy and it was in the realm of research at that point. And still it's expensive, hard to do. We don't routinely use MRI. But they had come up with what's called BK ultrasound machines, and this was I think a Danish company that created sonars for World War II, and they had created these really cool ultrasound machines, and they had created these specialized probes for colorectal surgeons. And I saw this and I said, wait a minute, if I put this inside the vagina, would I be able to see all the things that they need to see? So I literally suckered the company to loaning me one of these machines, and I took it to the cadaver lab, and don't want to gross your audience, but I'm an anatomy professor, so I dissected a lot of cadavers, and I ultrasounded a lot of them, and I correlated the anatomy of the cadaver with what the ultrasound was showing. That now has now become the standard for looking at pelvic floor anatomy. And just to put it in perspective for you, when we talk about ultrasounds, there are two types of ultrasounds. And this is something we get a lot, people would reach out to me through Instagram or Facebook and from Europe and say, somebody did this ultrasound on me, and they do a perineal ultrasound. And this is not the same as what we do. We do an endovaginal ultrasound, and the reason this is important is you're literally getting a very small probe that is not uncomfortable at all inside the vagina, but it's very strong. It's like 16 megahertz of energy, and the muscles are literally millimeters away from it. So when you do the ultrasound that way, it's just like looking at the histological slides of the muscle. So nothing really escapes you, and it's hard to show superiority of one technology over other, but I always put MRI and our ultrasound side to side, and our ultrasound always have so much detail in them.
Yeah.
So I published that and presented that, and again, people got up and said, "Who cares? Why are you showing it?" They're like, "Come on, you really need to know this stuff."
Why do you think there's so much? To me, this is just it. First of all, it's mind-boggling that there are muscle fibers not being identified. It's also mind-boggling that nobody is standing up and celebrating and sending this out to the masses. Now, of course, I'm biased. I work in this field, but why do you think that is?
I think you just need to look at what people do. I have always been, a little different. So I always ask why, and then I really never, I don't think I actually did things the way that my mentors told me to do it. I always say, okay, I really think this is a better way of doing it. And I think what probably gave me the leg up was that I just really have done, probably 500 cadaveric dissections. Wow. And I've done so much studies, So I really understand the pelvic floor anatomy. It's just like being a engineer and going and looking at Golden Gate Bridge and say, yeah, these are all the components. And your pelvic floor is really built like a bridge with all the suspension cables and so on and so forth. So I think other people, they just want to do their surgeries, but I'm really interested in understanding how this bridge works. Right. If a part of it has collapsed, it's not just enough to go and you put a plank over it and just go to the other side. You need to understand why it has collapsed, what were the forces, and rather than putting a plank over it, go and actually repair the suspension cables that snapped and caused that area to collapse. Or if the foundation was an earthquake under the foundation of the bridge, that's where you need to go and work on, rather than just keep trying to fix the bridge. And that's really what you see a lot of times, where people say, well, pelvic floor surgeries have a lot of failure. Like, well, it depends on really what are you actually repairing. Do you understand what you're repairing, or are you just are you putting stuff to stuff and wondering why it failed?
Right.
So that's where we are.
And so in terms of when I said there's a lot of people watching you, in the pelvic health realm, there's a birth injury called Levator avulsion, Levator anti-avulsion. And this is something that statistically, at least that I have seen, it's around 30% of vaginal births, and there is some resolution for some. I don't know if you have any different statistics on that, but this is a very specific injury that not very many surgeons have the knowledge of how to repair it. And I know that there are some that maybe are not repairable. So we're going to go into more about that. But first, you've talked about the anatomy and the importance of identifying the anatomy. If you can talk a little bit about what are the muscles of the pelvic floor, and then specific to the levator ani or levator ani, however you would like to pronounce it, what are the muscles involved?
Yeah. So, Kim, if you don't mind, I'm gonna roll back a little and just give you an analogy that somebody gave me one time, and that really made a lot of sense to me. It was, the current state of science is that you're standing there and bodies are getting washed down the river, and you're just going down there and pulling them out of the river, and you are resuscitating them. But then somebody needs to come and think, where are these bodies coming from? So that's the analogy for pelvic organ prolapse, urinary incontinence, pelvic floor disorders. It's true that you have a problem now where we are standing by the river, but really where did this start, right? So in terms of pelvic floor injury and levator ani injury, that's really where the problem starts. So just the analogy I use is that, you have connective tissue, you have muscles, you have things that are just like a bridge that are holding you together. And then if you snap a few of the cable, the bridge would still stand on, but it would be much weaker. And then over the years, just cannot sustain the forces, and then it's going to start causing prolapse, incontinence, so on and so forth. So a lot of people basically ask the question, like, why do we even care about these muscles? We just do prolapse surgery. Why should we go back upstream and look at these muscles at all? We are down here 15 years, 18 years later, and we are seeing patients with prolapse, and we are doing surgery on them now. So really changing that mindset that these muscles are important at all is the key, right? Now, when we go upstream, where the injury occurs, right? You just need to remember, as a girl who got married, who has dreams, who really doesn't know much about pelvic floor, and who just wants to have a family, what's on your mind about childbirth is very different with probably the experience you have now. And you would say, gee, I wish somebody told me this stuff before I went through this. And the problem we have is that the way that the society views childbirth as, I'm going to go there are going to be waterfalls and rainbows, and it's going to be great. But really not understanding even though the percentages is really low, when the problems occur, what are these problems and how can we address them? So going back to the question you asked, we really don't use the term avulsion as much, again, because if you're using a technology that is not as accurate or maybe as sensitive, maybe if you're using a perineal ultrasound, they would tell you avulsion, no avulsion. It means that the muscle snapped from the bone or the muscle didn't snap from the bones, right? Now, the reality is that these muscles are very complex. Imagine like the bowl that you use in your kitchen, and just you put dough all over it. And that's what these muscles are. And then you're going to stick 3 holes in them for the urethra and the vagina and the anus to go through them. The muscles are very complex in their structure. True, at one point they're attaching to one part of pubic bone, but a large percent of it, 99% of it, 98% of it is attaching to the side walls. So when we use the term avulsion, we are using the term that orthopedics use for your shoulder muscles, and say the muscle tore from the bone. So it avulsed. So the same term was used in the pelvic floor when the muscles are just so much more complex. And then when we do endovaginal ultrasound, we can see these muscles in all their details, in all their subdivisions. And the way we looked at them is really tactical, where it's just like having bright eyes and looking at again, Golden Gate Bridge and say, this cable has snapped, I need to change it. This support structures has snapped, I need to change it. So it's very tactical. It's not avulsion, no avulsion. But going back to the question you asked, the true avulsion in our mind is when the muscles, puborectalis, pubococcygeus, iliococcygeus, come undone from everything. So if I see a patient where I see those three muscles basically are totally undone from the whole. So imagine again, just if you have that bowl with the dough in it, imagine the whole dough has pulled us from the side and is sagging on one side. Or if you have bilateral injuries, like all of the dough has come undone on both sides of the bowl. So the true avulsion incidence is probably around 13%. The truth is that we did a study where we actually ultrasounded patients, and we didn't look at avulsions, and we just looked at all sorts of injury in the pelvic floor. And what I mean by that is that as you're delivering the baby, the muscles just stretch, and they have to spread as long as they can to let the baby to go through. And then what happens is that as the muscles are literally stretching and shredding, they create small hematomas, they create small blood clots, or sometimes gigantic blood clots in there. But when we did this, somewhere about like 45% of patients had large blood clots. And when if we look at patients with the smaller blood clots, it tends to be like around like 70%. So that I don't call these injuries, I would call these physiologic changes, because the muscles have to stretch to let the baby through. But when we ultrasound the same patients a year down the road, really most of all those hematomas and blood clots have gone away. So what the body does is that it goes and muscle has shredded in the middle, it comes and sort of repairs it, and then maybe scars it. The muscle won't be as strong, and that's where even women who don't have avulsion or injury, they just don't feel like their muscles as strong anymore. That's because the overstretching of the muscles. But when the injury comes from their point of connection, so like iliococcygeal connection to obturator internus muscle, or pubococcygeus connection to obturator internus, and then pubic bone, and also like puborectalis attaches to both pubic bone and obturator externus. So if all of those connections come undone, then then you have avulsion, and that's about 13%, and that's what we call catastrophic injury.
Yeah.
And if you're one of the people who have actually had this happen to them, it was catastrophic, and you probably don't have to wait 15 years to get symptoms, like I talked about. Then you basically may have prolapse immediately, may have rectocele immediately, you may have uterus fallout immediately. One problem that we have is that, just going back to the birth process, is that, remember, nobody can tell you how the birth process can be or how you feel. It's a different thing for each person. But in all this swelling and soreness that you're experiencing, you really can't differentiate if you had muscle injury or you did not.
Yeah, that's such a good point.
Yeah, you literally would just lie there and say, this is normal, and nobody else is complaining about this, so why should I be a wimp and complain that I'm sore? And then the problem with that is that even in patients who don't have muscle injury, right after childbirth, when you do vaginal examination on them, everything just looks out of distorted. So when a physician looks at the vagina after delivery, they would say, well, this is normal. This is just the way it's supposed to look. And they really don't have any way of saying if there is muscle injury or not.
Right.
So, so generally, if you're feeling like that, and you know, I don't know, 2 weeks, 3 weeks has gone by, and you're still feeling that discomfort, something is wrong. You need to see a specialist that has really expertise in what we do, and they are few and far in between. So you really don't want to just see a urogynecologist. You want to see a urogynecologist who has some degree of imaging expertise. Either they know how to do at least maybe MRI, or maybe do transperineal ultrasound. And the ultimate, in my mind, obviously, is if they can do what we do, which is an endovaginal ultrasound. So
It's honestly shocking to me listening to you talking that. So I've already asked you the question of the people who are looking at what you're presenting with your research and your thesis statement, and no one's really giving much interest. And then when you talk about the statistics you just threw out, and also just even if somebody again doesn't walk away with a catastrophic injury, there's disruption to the tissues and to the function in every single person giving birth vaginally. And why is there not more attention given to prehab and rehab? And in my opinion, pelvic floor physical therapy is something that I think should be playing a vital role in all births to help rectify or at least identify some of these things before. Because as you say, people come out and they of course feel different, but they don't know, they have nothing to compare it to. So they don't necessarily know if this is catastrophic or just how, how it is. And I just honestly am floored. But so you being one of the few people who has the imaging, but also who is doing repairs for these injuries. So why is it again that there aren't more people wanting to get trained by you, or the people who trained you potentially to learn these practices, knowing that these are such common injuries?
yeah, so I think I'm going to just roll back a few sentences, if you don't mind, Kim. Just I think having patients prehabilitate or see the physical therapist or whatever we are proposing to them without having an accurate diagnosis is just going to frustrate the heck out of them, right? Because the physical therapists, I love them. We have 20 of them, 20 pelvic floor therapists that in our health system. I'm totally with you, but they have learned to just like come back to me and say, what was the accurate diagnosis of this patient? What did the ultrasound show? Because, I mean, they always are like texting me, messaging me, like, what did your ultrasound show? Because, and what is that you're recommending? Because if this person had muscle injury, I don't want to do the things that I was going to tell them, right? And then, but that's, what you, I mean, I really don't get floored or shocked. I just see a problem and I say, how can I solve this? And I empathize with the patients and I try to find solutions for them. There is a great interest in this area, but you just need to see the enormity of the problem, right? So basically, if one thing that I'm really passionate about in this population and that just gets my heart bleeding is just a lot of times the ones that they see also have PTSD, like they have postpartum PTSD, and especially with them, like when I do ultrasound for them, say they have been going around for like 3 years trying to figure out what's wrong with them. They have seen physical therapists, they have seen this person, that person, and the psychiatrist is saying, you just need to take more medication to get this PTSD under control. But they really never had an accurate diagnosis because they keep going around and telling people there's something really awfully wrong here that wasn't wrong before. But once we ultrasound them, I wish I had a study like to get their facial features, because I mean, sometimes it's just like let down and crying because they're like, oh my gosh, there is actually something wrong with me, like I told all these people. And sometimes there's this relief of saying, I can deal with this. I have a problem. Now I know what it is. So accurate diagnosis is the key. Now, when we talk about the enormity of the problem, if we say, when we look at 3 to 4% incidence of PTSD in postpartum population, you're talking about like 120,000 patients that basically go undiagnosed without an accurate diagnosis of PTSD, and they're never treated. They live their lives like that. And if you go with like 12% or 13% risk of avulsion, then you're talking about like 400,000 patients that go undiagnosed in the United States alone with Levator and avulsion. And these people will either have problems immediately, or they will have, problems down the road, or sometimes you just say, this is how it's supposed to be being a woman, childbirth, this is what it is. But the problem is enormous, and I am training physicians all the time. Any conference that there is, Shobeiri is giving an ultrasound workshop. We have international research folks coming here to learn what we do. They go back to their own countries to learn how to do it. And then it's just that it's a core competency that physicians don't have. The OBGYNs are trained to do ultrasound, to look at your uterus and ovaries, but it's very different with doing pelvic floor ultrasound, for looking at pelvic floor muscles. So we at INOVA, we have, I think we are the largest fellowship training program in the country, and we have like 6 fellows. But literally every fellow that works with me, literally they have called me back. They say, we have to rearrange our wiring when we go back to other services, because now we are used to looking at patients' insights, seeing what, making the diagnosis that way. And now we go into the real world where things are a little different, and we just have to switch back. So, we are training people, but really just changing the whole structure takes a long time. But that's why, I accept your invitation to come and talk on these kind of programs, because patient education is huge, for women to know that there are solutions, and seek those solutions, and just don't take the answer that is given to them. You just have to be a smart consumer.
Yeah, well, that's good to hear. I appreciate you saying that, and I appreciate all the work that you're doing to train other people, because it is definitely needed. So we've talked about the group of muscles, the levator ani, what makes up that muscle, the group muscles. I love the dough analogy in the bowl, and you mentioned how it can be one side or potentially both sides. So regardless of whether it's one or both, what is the repair of, and I don't know what the other term is that you use that's not avulsion, but right now I'm calling it that because that's what we know. But how do you repair, whether it's a unilateral or bilateral avulsion?
So basically, when you use the word avulsion, you're basically saying that there are 2 types of injuries, either avulsion or no avulsion. When you look at all these different muscles, and you become tactical in each one of them that may get injured, there are 36 different varieties of injuries that a woman can have. So when we look at that, we would see a patient and we would say, okay, you have like defecatory dysfunction, pooping problem. It's something that people are saying that, it has to do with your GI tract. But what happened was that you tore up your iliococcygeal muscles, and your rectum, rather than being a straight like pipe, it's a wide pipe where the stool just connects there and you can't poop. So it's very tactical. So you need to know the anatomy. It's like if this muscle, where does this muscle normally sit? I'm going to dig down and I'm going to find it and I'm going to pull it up and I'm going to reattach it to where it's supposed to be, right? So that's how the surgery is done. The so there are two issues, like two core competencies that we need to teach physicians to be able to do this surgery. The number one core competency is teaching them how to do ultrasounds, or imaging of some sort if you don't have ultrasound available to you. And these technologies are expensive. Sometimes the hospitals just don't buy it for you. At least be able to do MRI or something. But if you are able to get the ultrasound, that's it's not the machine that you need, it's the knowledge that you need to have. So really, literally, for my fellows, it takes them a year to learn how to interpret images and how to dissect the images. So basically what we do with the ultrasound, we are dissecting the patient on the screen in front of them. The ultrasound literally takes about 5 minutes to do, and as they are sitting there, we go and look at the data and we say, look, this is where your problem is. And it's actually very educational for them. So I really feel like, first of all, ultrasound, we need more people as mentors that need to know how to do ultrasound, but these are older folks, so it's hard to teach them stuff, right? And then it needs a year, they need to take a year off to learn something, and they're in their 50s or whatever. So we need to get it in the training programs to be part of our regular urogynecology fellowship programs, right? The other thing that we probably should do is just have straight ultrasound fellowship programs where we say, great, you did your gynecology fellowship in such and such place and they didn't have the ultrasound expertise, but here we are offering you a 1-year program to do this. Again, then it's a manpower issue, and we do offer something like that where people are coming and getting those training. So once they have that core competency of doing the ultrasound, the next core competency they need to have is surgery, right? Now we are asking them to do very delicate surgeries where you are literally doing microsurgery of connecting this very wide, delicate muscle to different structures. So people ask me, like, how do you do it? I'm like, well, it's hard to explain. You just need to understand the anatomy of the Golden Gate Bridge and know which wire needs to go to which area and connect them to that. So if you really don't understand the anatomy, then it's really tough to teach you. So there are some good surgeons there, and I'm pleased to say that, like, at least our fellows, when they are graduating our program and etc., I think they have level of confidence to go and do it. But then the question is that wherever they are going, do they have the resources to do the ultrasound, to keep up? And then really for me, my practice literally dedicated to postpartum patients, where I'm just like, okay, she has postpartum, I would see her. She doesn't have postpartum problems, I won't see her. But then it's difficult to say who is postpartum or not. If the patient calls and say, well, I delivered 15 years ago, but I attribute my problem to that childbirth, then I need to see them, so
that was a question I had actually is, because a lot of people will say once you've given birth, once postpartum, you're basically postpartum for the rest of your life. So does it matter in terms of the success of the surgeries? Does it matter how soon, or like if somebody waits that 15-year postpartum person who finally now has some answers because they've found you, is it too late, or would it affect the outcome? Would it be better if that person had been seen earlier and had the surgery done within a year or 2 years?
So this is just like paddling across Potomac and trying to figure out what's the best way to get to the other side, and that's what I've been doing, literally trying to answer these questions. First of all, remember, it took me literally, 20, 30 years of trying different things. And I have described many different ways of repairing these muscle injuries, but I think we're at another level the past probably 5 years. And what we have learned is that, so for example, if you are the patient and you delivered and you come and see me and you say, I delivered about 2 months ago, something is awfully wrong. The protocol we have developed is that you would get full assessment, physical examination, questionnaires, etc., and you get ultrasound at the same setting, right? And the ultrasound, like 2 months after delivering a baby, just looks not great, no matter who it is. It's just like there are a lot of blood clots, etc. And I say, okay, we have a baseline of how things are, and we are going to, the protocol calls for ultrasounding you in 6 months and then 6 months afterwards, right? But the point is that we need to ultrasound you a year after and see how much healing has occurred. And that's one thing that we are researching in our center ourselves, because, why is that, again, me being the curious person, why is that two women who look alike, act alike, had seemingly exact same delivery, and maybe even seemingly the same injury, heal differently? Right? Why is that when I see them a year after, patient A has persistent injury and patient B has healed? Now, I believe that if they have true avulsion, which is tearing off puborectalis, pubococcygeus, ileococcygeus all together, nothing magical will happen. The muscles are not going to magically crawl up the sidewall of the pelvic floor and attach themselves where they're supposed to be. But then I think with that 1 year, we are giving them enough time for the dust to settle for us to see what has remained and what we can do. But once we have established and we say that this is the problem you have, then we really need to see where in the reproductive life cycle we are catching the patient, right? Is this your third baby, or is this your first baby? Was your dream to have 2 babies or 5 babies? What's going on? I generally basically recommend, please get done with your childbearing. If they have had true injury, I would recommend for them to have a C-section for the next baby. There's no point, sometimes they tell me like, well, it's injured, isn't it okay? I'm like, no, it can get injured more. Don't injure it more, it makes my job harder. So get a C-section, and then when you are done with your childbearing, then we assess you at that point and give you surgical repair options, right?
Sorry to interrupt you. I just have a question on that. If somebody has, let's say they have a unilateral or bilateral avulsion, mm-hmm. Does that change the capacity of the uterus at all during the pregnancy? Does it make things more challenging for them to even carry a pregnancy?
That's a really good question. A lot of patients just ask that. I'm looking at this screen and I'm like, oh my gosh, you tore up your muscles, and she's thinking, can I get pregnant again? I'm like, yeah, you can get pregnant. So it doesn't affect their ability to get pregnant and carry a pregnancy. They probably would feel more pressure and discomfort, and they may even have prolapse during early stages of pregnancy as the hormones kick in and make things lax, so and remember, when these injuries occur to the muscle, if you're exerting so much force to your pelvic floor that the muscles rip, more likely than not, there's some connective tissue injury as well. So when we say, for example, if I have a patient that I identify that, for example, she has a right-sided ileococcygeus and pubococcygeus injury, and I go repair that, at the same time, I'm going to repair anything else that I see at the same time, that I can identify as weakness, to try to give them the best chances of healing. So, yeah. And sometimes, again, if they do have prolapse, and so on and so forth, and really there is big structural damage to both connective tissue and the muscles. The muscles give you about 50% of the support, so the other 50% that we need to go and correct everything. So
then coming back to the, I know it's it's intricate, and I appreciate how long it's taken you to become trained in this. The question, though, that so many people have is, how do you actually take those muscles and reattach them? Do you reattach them to bone? Do you suspend them from other areas? Is it with mesh, or is it with native tissue?
So basically, we use sutures, and we use sutures, pull the muscle up and connect it to wherever they connected to before. And you literally never need to connect it to bone, okay? Because, and that's really one thing. Sometimes I get people send me questions like, do you screw it to the bone? Do you suture it to the bone? What are you doing? I'm like, no. Where the muscle was attached to the bone, there was a ligament there. And so you basically can get the end of the muscle that is scarred now, and you suture it to that ligament. But remember, again, that part that people concentrate on is literally, 5% of the whole area of connection. The rest of your connections are, like if you're talking about ileococcygeus is, I'm going to throw medical lingo out there so people start breaking down Google engine. So yeah, like ileococcygeus is, its point of attachment to the side wall is arcus tendineus fascia pelvis, that is attaching itself to the obturator internus fascia, right? So when we get in there to repair these things, sometimes the arcus tendineus, which is a ligament structure, it can be anywhere. It can be stuck to the side wall, can be floating in the air like a piece of wire, can be attached to the muscle that is retracted next to the rectum. And then, so you just need to literally, like closing a zipper, you need to put suture, stitches, just put it back where it was at one point, and then you just keep on going.
Got it.
So we always, like before surgery, looking at our ultrasound, say these are the defects, and that's really the other gratifying thing that I must say is like there's still a debate that really all these things that you see on ultrasound, like are they real, or do they exist? We literally have not had anyone we did surgery on where we went in there and ultrasound said that showed a defect, and then we didn't see that in the real patient. So that has been very gratifying.
That's amazing. So the integrity of the person's tissue is really important. So if it this is coming back to the one question I asked with regards to how long after, so some people could be, say, 15 years after this injury has happened, potentially this person is now approaching menopause and there's a hormonal change that is starting to happen to the tissue as well. Can that influence the success or the capacity for those sutures to hold?
Basically, longer it takes after childbirth. When I go in there, I can tell you, like 10 years later, when I have attempted to go repair them, I'm basically looking at fatty tissue and really no usable muscle tissue to use, because the muscle, as it's detached, it literally atrophies. We still go and try to look for them. We really don't have enough data to say, but all I have learned and all I know is that earlier I can go and put the muscles back together, better success I have of finding them.
Yeah, that makes sense. And this is not necessarily a question particular to avulsion, but general pelvic surgeries. Would you say the same would be true? That so somebody, many people are told wait as long as you possibly can because there's a chance of recurrence, so you might as well delay your first one, knowing that that's going to happen. But there's the other argument, which is sort of what you were just saying, where if we wait too long, there's more sagging, there's more drag on the muscles, there's more atrophy to the muscles. So potentially the person is faced with an even bigger surgery afterwards. So kind of sooner is better. Is that accurate to say? Yeah,
drawing from other disciplines where, that's what we know. We know that if a muscle injured, sooner you go and put it back where it's supposed to be, more functional it is. Now, having said that, in real life, as a pelvic floor surgeon, I'm very conservative, right? If a patient comes to me, I don't know, in their 40s, 50s, and they have prolapse, I basically do all the conservative things that I need to do to try to give them the quality of life they want, because that's what it is about. It's really not about correcting prolapse probably, but it's just giving them quality of life. And if it has already been so long after their initial injury and the muscle injury, I won't be able to correct the muscles at that point, and we see this as a matter of fact, like when the patients are early after delivering a baby and the muscles are disconnected, you can actually see the muscles right sitting there, and then there is a black area between where they are and where they were supposed to be, and that can be measured. Versus when I look at somebody who is many years after delivering their baby and we do ultrasound, literally all we would see is just the vagina and the rectum and urethra and etc., and the muscles have turned into fat. So on ultrasound, fat looks black and dark and there's no muscle striation there. So with these people, we know already where their muscles and what the status is, so we don't even go after them.
So that would be somebody who, like in terms of who would be a good or not such a good candidate, somebody who has lost some of the muscle striation, it's maybe been a longer period of time since the injury happened, they may not have a successful outcome and you wouldn't necessarily go forward. Is that correct?
I basically rely on their ultrasound, because if the ultrasound shows me muscle and it shows me it's there, then I know I have something to go after. But if it's just not there, then I know that, we don't want to do unnecessary surgery for patients either, right? So,
are there any of the muscles within the pelvic floor that cannot be repaired? So are there any, injury presentations that are beyond repair?
We have seen them on, and we have. It's really like being a carpenter and being knowing the anatomy of the room that you're working in. So you just go in there and put things back together. The iliococcygeus, pubococcygeus, puborectalis, they can all be repaired. They not muscles, but there are some connective tissue that are harder to repair, like perineal membrane, deep fascia, etc. They're harder to repair, and also like puboanalis injury. That's a lot of times we see patients who have like anal pushing of the anus, like the anus doesn't have the support because the muscles just have been disconnected, and those really there's no good way of repairing puboanalis muscles, and then that would be more of like a colorectal thing where they go get mesh, push it out on the rectum and pull it up that way.
Do you ever use, sorry, go ahead.
Yeah, but puboperinealis, puborectalis, pubococcygeus, iliococcygeus we fix. I think puboanalis is the only one that probably is a colorectal issue.
Do you ever use mesh, or is it just sutures?
We don't use mesh for muscle repair. We use mesh for strengthening the uterosacral ligaments. So basically, if somebody has what we call apical prolapse, means that if this is the vagina at the very top where the uterus is telescoping through and you need to support that ligament, then we basically open up the uterosacral ligament, put mesh in it, and then bring it wherever we need to. And that's called sacrocolpopexy for the people who are not familiar with it. So we do that for apical support, but really there is no advantage to using mesh for muscle repair, because you just need to get the muscle and put it back where it needs to go.
And are the surgeries performed through the vagina?
It's a combination. I generally do them robotically and vaginally.
So there was a study that came out, I think it was just sort of a review of a number of different, you may have seen this, but talking about the use of robotics and how it can it can help with some of the more intricate aspects. So when you say some robotically and some vaginally, where does the robot go? Like where does that incision happen?
Yeah. No, it's when we say some robotically, it's in the same patient. So, for example, if I see a patient with pelvic floor injury after childbirth, the chances are that almost 100% that we do both robotic surgery and vaginal surgery on them, because of the question you asked, like where are these muscles going to? Some of them are easier to reach vaginally, some of them are easiest to reach robotically. So when you do robotic surgery, robotic and laparoscopic surgery, just for the audience, they're literally the same thing. Okay. Laparoscopic surgery, you use little things that look like straws and put it through the belly, and then you use that to put the instruments through. And that way the patient doesn't have a big incision to do what you need to do. But it's really cumbersome for the surgeon. By the end of the surgery, you have a horrible backache and etc. So robotic, what happens is that you put the same sort of straw instruments in the belly, but then you bring the robot over the patient, and then robot will be following your commands. So you would be sitting on the side, you're sitting comfortably so you're not getting a backache, and then you're doing your surgeries with the robot. So robot doesn't make you a better surgeon. You have to be a good surgeon to use the robot to its maximum potential. One advantage that robot has for us is the spaces that we go into are very small. You're literally talking about, for example, you can see on the ultrasound that the iliococcygeus muscle, for example, is torn from the side wall, but when you measure it, it's like it's torn about a centimeter. So a centimeter is a tiny amount, and then I need to go find it and bring it up and suture it back up. And the same thing with the other muscles. So the degree of separation of the muscle is not really great, but when you're talking about pelvic floor hiatus or levator hiatus, literally it's a hiatus about that big, where the bone is here and the muscles are going around. When you like have a 1 centimeter separation, your small muscle hiatus becomes really much bigger than it's supposed to be. So just the biomechanics of it is such that you just need to have really fine instrument handling to get into the space that you need to get to, and you cannot do that with laparoscopy. And then the spaces that you want to think about, just imagine you're sitting, if you touch right where your pubic bone is and like where the clitoris is, like we are behind the bone, and that's how low we are in terms of trying to get your muscles. But the instruments are going through your belly button and etc. to get that far down. So that's the other thing, is that with laparoscopy, sometimes our instruments are not long enough to get way down there. So then you do iliococcygeus, pubococcygeus, like puborectalis repair. All of that can be done robotically, and then we do also fascial repair, and then we go vaginally and then repair the other things that need to be repaired as well.
How is the fascia repaired?
That's a big question. I think my question for you would be which fascia, right? So there are many different ways of basically repairing the fascia. With the muscle injury. So I'm just going to use this paper that I have here, and I'm going to use it for analogy. So if this is the tissue that sort of goes under your bladder, and your bladder is sitting on top, the muscles are on the side, right? So when the muscle tears up, what happens to the bladder is that the tissue doesn't have anywhere to attach itself to, so the bladder falls. So you get a cystocele, right? So if you go see a normal person who looks inside their vagina, they're like, hey, you have a cystocele, I'm going to go through the vagina and repair it. They really wouldn't know that you have muscle injury So they go and get this tissue and like sort of bunch it up and stitch it up, and that actually makes your cystocele worse. So that's why it's actually important to do ultrasound to see what's the patient's underlying problem, right? So for us, say now the patient has a cystocele and their muscles were here, but now they're down there, right? It's not enough for me to bring the muscle up here and attach it where it was. Now I have the tissue sort of still floating down there. I have to bring the tissue and attach it to the muscle as well, right? So you end up not only doing muscle repair and also doing maybe a paravaginal repair robotically, but it's really important to remember that like paravaginal repair is not muscle repair, and that's sometimes what I get questions on. Like people reach out to me and say, is this what you are doing? I'm like, no, we are getting the muscles and we are putting them where they belong. And then so that's like one type of fascial repair. On the other hand, if your muscles are intact and the fascia is attached, and maybe when you deliver the baby the fascia tore right in the middle, and you go see your general OBGYN or your gynecologist, whoever is doing your fascial repairs, when they open the tissue vaginally and do just what we call anterior repair, it's going to take care of your problem. So again, you just have to have really high level of curiosity, clinical acumen of saying, this is a muscle problem, this is a tissue problem, and then basically the connective tissues that you need to know just to educate people. You have a tissue that separates your vagina from your bladder. That's called pubocervical fascia. And then you have, again, another tissue just same way that separates the vagina from the rectum. And that's called rectovaginal septum, right? And then I don't have two hands, but just if I'm going to use the same paper, so if let's see, can you see it? So if this is the tissue that goes under the bladder, that tissue that goes under the rectum, your uterosacral ligaments are coming from the corner and holding this up on both sides. So they are supporting, the uterosacral ligaments are pulling your pubocervical fascia and rectovaginal fascia up, right? So there are many different ways of repairing the fascia, because again, if the uterosacral ligament has come undone, for me just going and putting a suture stitch right next to that corner is not going to be enough contact point. So in those cases, I'm not using mesh for muscle repair. I'm going to, just like an orthopedist, I'm going to reinforce your uterosacral ligament with mesh, has a wide attachment, and then I come and grab the pubocervical fascia, grab the rectovaginal fascia, and pull the whole thing up. So your muscles are repaired, and your fascia has been strengthened.
Got it. So I think you sort of answered the question there that I wanted to ask, is that fascia can be restored either with the help of mesh into ligaments or with sutures, correct? Yeah. So you can use sutures into the fascia as well.
Yeah. You can use, the fascia is harder to see than muscle. So we can see 100% certainty that, you have muscle problems. If you're a normal patient who has never delivered a baby, I can easily see your pubocervical fascia and rectovaginal fascia. But once the fascia gets injured for one reason or the other, it's harder to see on the ultrasound. So you have to sort of use your clinical examination, physical examination, and ultrasound knowledge together to deduct what needs to be done. So what we'd like to do is really go and correct all the defects that we see while the patient is under anesthesia, so they won't have to come back and say, hey, I have this problem. Now, having said that, sometimes we may do surgery on patients and they may come a year later, 6 months later, 6 years later, and say, something is pushing out that I didn't feel before. I can tell you generally, like in our surgery, the patients never fail where we did surgery. Where they may fail is just, again, going back to the Golden Gate Bridge, is that we went and repaired all the floor and we repaired all those cables that had snapped, but now they have snapped some cables that were not snapped before, or part of the floor is giving up, where where I didn't need to repair because it looked normal to us at that point. But because of the aging, because of the tissue changing, now something else has come undone. So it's not the failure of surgery, it's really failure of the body.
Got it. So would you, are you a supporter of pelvic floor physical therapy after surgery and on an ongoing basis to help prevent or mitigate the chances of that happening?
Oh, absolutely. So I'm going to use another analogy for you, Kim, and that's my analogies hopefully are not going to just drive you crazy. But just she's like, this person is giving me too much analogy.
I love the analogies. They're helpful.
Yeah, good. So let's do this. I'm going to create a pelvic floor for you, right? So say, can you see this? So this paper that I just turned into a cone, think of it as your connective tissue, right? So it's connective tissue. I'm too close. So yeah, that's actually better. I was too close. So this is your connective tissue. Your vagina, your rectum, your bladder, everything are going through there, right? And then if I'm going to get my eye drops and just make it, that's your uterus, and we're just going to drop it in there, right? So pelvic floor exercises are these muscles that are holding the opening of the cone closed, right? If the fascia is weak, obviously if you strengthen those muscles, it's going to some degree help you, but it's really not going to correct that problem, but it's going to help the strength of your muscles. Now, the problem we talked about was that what if you don't have muscles, right? Now, if I send you to physical therapy, it's going to really frustrate you and frustrate your physical therapist because you're not making any progress. So sending the right person to physical therapy is a great idea. And as a matter of fact, for us, because we know the status of all of our patients are going to PT afterward. But basically, again, just going to that, just see what happens when I let my hand go, the eye drop literally just falls out, right? Because the muscles have weakened and then the connective tissue literally unravels and things come. So physical therapy is very, very important to strengthen the muscles that you have. And again, just not to diminish physical therapy if you don't have intact pelvic floor muscles, because there's a lot, the physical therapists manage you in a holistic manner, right? So just when you look at your pelvic floor like a Roman bridge and the Roman arch, when the integrity of that Roman arch is compromised, your posture is not the same anymore. The way that you handle your body is not the same. The way you are breathing is not the same. So a physical therapist may not be able to strengthen your pelvic floor, but they would do other things that would compensate. So the way that you would, for example, breathe would take the pressure off your pelvic floor. So just again, we have 20 some pelvic floor therapists, and they're too busy. We need more. If you need some, send them to us. We'll hire them.
Yeah, the world needs more pelvic floor physical therapists. I agree. So I have a couple of questions. How long do the surgeries, and obviously it's going to be dependent on what you find in that person, but how long would it typically take to repair, say, a unilateral avulsion? And then I'm curious about the recovery time, and also if there are limitations that people have. It's very common for people after, say, a prolapse repair to be given lifting restrictions, sometimes given lifting restrictions for the rest of their lives. So I'm curious about, are there any lifelong restrictions that these people will have after they've had a surgery with you?
Yeah, that's such a really great question in terms of restrictions. The answer to that is that really nobody knows what's the right thing to do afterwards. One thing that I do know and makes a lot of sense is that whatever you do, don't do squatting exercises, right? Squatting is like, if you go to third world countries, that's a position for peeing and pooping because it relaxes your pelvic floor, so you can do those actions. Or if spreading the legs just really relaxes those muscles. So don't do squatting exercises. I'm sort of answering your question backwards. Like But don't do that in terms of heavyweight lifting. Again, it's not really as important how much you're lifting, it's how you are lifting it, right? Again, if you squat and you lift 10 pounds, the pressure that goes to your pelvic floor is tremendous, versus if you get on one knee and lift 100 pounds, none of that goes to your pelvic floor. So again, just this is one area that a good physical therapist can really guide you on, and that's what we tell our patients: go and work with the PT, and they're going to help you with handling and lifting and so on and so forth. Going back to other questions, really, how long do these things take? With the area is highly vascular. As a matter of fact, like when we look at the ultrasound, there's like blood vessels all over the place. So when I do surgery, I'm not looking at the clock. I'm just thinking of my patient safety. I'm going slowly and surely and just doing my things, So it depends on what, and we never do muscle repair alone. It could take, depending on what we do, it could take anywhere from 4 to 6 hours. So not really easy things to do, and they're lengthy things to do, and they're very meticulous, and they're very, I don't know, it's, if any of you do quilting, you just have to have a beautiful outcome, you need to be very methodical on what you're doing.
I marvel honestly at the work that you do and the use of robotics with it. It's fascinating. So thank you for being curious and doing all the things that you do. And I want, just before we start to wrap up, I'm also now curious with regards to success rate. So the how many of these have you performed? What's the, if you think back to the first person you did, do you have any sort of long-term data? How long are these surgeries lasting? Do people need to have multiple surgeries over a lifetime? You may not have the data on that yet, but what sort of figures are we looking at?
So yeah, you're not looking at great number of figures because, again, just a lot of these patients, as I told you, we identify injury, but they won't do surgery on you. Basically, I say, go do your reproductive life cycle. I'm here for you. And then we'll go. So patients are coming back. But we just looked at it and we haven't published it yet, or hopefully I would get time to do the full analysis and submit it for the American Urology Society meeting this year. I was going to send it to IUGA. I got COVID and etc., and they just couldn't do anything. So but I think we have done somewhere about maybe 30 of these repairs, right? And then right now I think about 18 or 19 of them are immediately postpartum. The success rate, I can tell you that patient-oriented outcomes are really good, where patients come and say, I don't have that pressure that I had anymore, and things have, I feel good about it, right? And then what we are doing, we are ultrasounding them afterwards to see really how things look like, and what we could do better or differently, and what are the reasons somebody may feel better than the other person. So again, just looking at this as carpentry, like I'm putting point A to B and just connecting things. So anatomical success rate is 100%, right? So because we're just putting things where they belonged to begin with. We have about maybe 3-year follow-up outcome where patients are doing well. They haven't had recurrence. There was one patient who was from out of state who told me she had pressure and she felt like she had recurrence, and they said, let's come back and for us to see you, and I haven't seen her back, so I don't know. And I think there was one patient that I tried to approach it vaginally first and it didn't work. That was before I was good at it robotically, and then we went to did it robotically, and that worked out well. So for most part, yeah, it's a lot of work, both for me and the patient. So I really don't have hardcore data in terms of like what they can do or what they can't do, but I basically beg them not to overdo it, even they're feeling great, because they wake up and they just have a few pokey holes on their belly and they're like, oh, this is great, I can go home, and I'm like gonna leave my kids and etc. I'm like, please, we just did a great, just great amount of surgery in your belly. Don't overdo it. Don't stress my suture lines, because even if we cut your hand, a small cut on the hand, and you look at it microscopically, it takes about a year for it to heal, So just because you're feeling good doesn't mean things are done and finished in there. Somewhere about like 60% of your healing happens the first 3 months, somewhere about 80% the first 6 months, but it doesn't complete for the whole year. So the body, once we do surgery, what body knows what to do is like it goes and dumps collagen in there, trying to minimize damage. And then after it thinks it has done a good job, it goes and reorganizes it and tries to make it as normal as possible. So we use permanent sutures. We use like Gore-Tex sutures to do the things we need to do for this to stay. And but then again, I just tell the patients to be careful, work with their physical therapist, work on their handling of their body, because again, we don't have 10-year outcome data or so on and so forth. And most patients that we have seen, not most, I think all of them don't have pure muscle injury. They have muscle and fascial injury. So we are correcting everything. And then going back to the success rate, again, remember, they're like, when we look at the types of injuries, we looked at like 200 patients that we had done ultrasound postpartum, and there were 36 different variations of injury. So it's really hard to say which group you are in. And really, I literally need to have, like 30 people in each 36 group to say that this is your long-term success rate. And I don't think I can accomplish that in this lifetime, unless all of your listeners get an appointment tomorrow.
Yeah. Yeah, that would take a little bit of time. And then, like from a recovery perspective, I love what you said with regards to it. It's not this like 6 weeks and you're ready to go back to normal, like so many people are told, whether it's postpartum or post-op. And there needs to be sort of it's a gradual progression back. It's taking things easy. And when you were saying how when muscles have come away and there's been some atrophy, how long does it take for them to regain some of their function? Like, are the muscles able to regain function once they are reattached?
Yeah, so that's actually interesting, because like when we look at the ultrasound, because as I said, the amount of separation is not that great. So when we go and suture it, because it's a surgical area, it looks like there is a still dark area and we just see a suture there, right? But functionally, it seemed like the patients are doing a lot better in terms of being able to squeeze, do Kegels, and knowing that they actually have muscles there. That, somebody reached out to me and said, my pelvic floor is dead. Like, I'm like, that dead feeling sort of goes away. Another thing that I wanted to say that I just want to stress, whether the patient has levator injury or not, it's whenever I'm doing surgery on a patient, their psychological state is really important to me. I'm a big believer that you heal your body, and really all of the healing is not up to me. I'm going to go there and put the stitches there, but this issue is really important for our patients with levator injury, because as I said, I'm yet to see a patient with levator injury who didn't have PTSD. And that's actually like a passion of mine. And I just, I saw one yesterday who was telling me about her symptoms, and she even used the word trauma from delivery and etc. And she's seeing a therapist and so on and so forth. And I said, has your therapist ever told you that you have PTSD? And she said, no, nobody has told me. I said, could you please go tell them that you need to see a PTSD specialist because you really need, this is what's going on. But that, getting past that PTSD to me is really important. And the way that patients describe it a lot of times is heartbreaking. But I don't know how much you know about me, but I actually I'm a professional painter. And the only thing that I actually paint is my patient's feelings. So sometimes I go home and somebody tells me something that gets stuck in my mind and I start painting that emotion. But just to advocate for the patients as well. But getting them to the baseline of being positivity and really just coming from a position of knowing that they can heal themselves, I think is really important to me. I've had patients that, not postpartum patients, but people who are just literally very negative and, and literally no matter what we do, it's just like a downhill and we can't stop it. So, yeah, be positive, whatever you do, and we can help you.
Yeah, I love that.
I know sometimes it seems hopeless, especially with our patients who have seen many physicians and many therapists and so on and so forth, but just there is hope out there.
I love that. That's a great way to end. I couldn't agree more. Your time is precious, and I really, really am so grateful that you have shared all of your knowledge with us. And all of the ways that people can reach out to you will be listed below. I'm also I love watching you on Instagram. There's not very many people like you who are sharing things on a social media platform. And I just, I really am so grateful. And I'd love for you to share some of your paintings. I think that is such a special way, as you say, to kind of process the feelings, because you take on a lot of the weight that these people are experiencing as well, right? When they're telling you their stories and so you have an amazing outlet for you to get that off your plate.
I wasn't much of an Instagram person, being an older person, but I realized my patients were younger. And a lot of times when they came to me and I told them things, again with the PTSD, it's didn't absorb. And sometimes it would take 3 months to absorb. So I'm like, okay, you're young, you're on Instagram. If you guys go to dr.sa.shobeiri, then that's my doctor Instagram account. So I basically, anytime I had a conversation with a patient, I went and recorded that for them. And I said, please go look at this video tonight and the day after, and just let me know if you have any questions. So the videos were made really for my own patients, but other people are finding their way to that. So if you go to Dr. S.A. Shobeiri, and then in terms of painting, I've always been a painter, right? And then I was just looking at my patients. I was thinking, how is the way that I can advocate for them? Because Levator injury and trauma is such a underestimated problem. It's under-recognized problem, and really, how can we let the society know that this problem exists, that literally 13% of our women are feeling this way and it's not acknowledged, and they have PTSD and it's not acknowledged. So how can we? So if the audience wants to look at it, is if you go to Shobeiri Art on Instagram and also ShobeiriArt.com. ShobeiriArt.com doesn't really have much of the painting; it's more of a platform. But the Instagram, there are some of the paintings. I do have if people are interested or in the area, I do have a solo exhibition of these paintings. And just for you to know what I did, I was looking at the patients and I'm trying to understand PTSD, which is something I wasn't really trained in. But as the years went by and people started telling me stories or the way they felt, I started grouping them together over a 20-year period. And I said, this is what Kim says is what Cindy said, and what there's a group that are exactly feeling the same, and this group feels this way. And I just couldn't make the connection. But then I realized that they were all sort of on a spectrum of PTSD recovery. And what it was like was that there's a cycle of mourning and loss that is well described. Some people describe it as 7 stages, some describe it as 5 or 9 stages. But the patients were mourning the loss of the functionalities that they had at one point. Now they didn't have it anymore. Whether it's sex, peeing, pressure, whatever the human being they were before this happened to them, now they were not the same human. So they were literally mourning the loss of that functionality, and they basically go through this spectrum of recovery. But if their physical injury, to me it seemed like if their physical injury is not diagnosed, they literally get stuck in one space. So if you feel such a tremendous anger and something is wrong with you and your life is a mess, but your physical injury is not diagnosed, you're going to be stuck in that anger stage or in the sadness stage or whatever that is. So what I did, I basically got those statements and matched them with stages and sub-stages of loss that the patients were experiencing, loss and recovery. And so the painting series is like 32 paintings that basically tell a story. So to do this, I actually had to find an appropriate venue, because no gallery is a long gallery that you can. So where we have it, it's called DuPont Underground, which is a old abandoned railroad station in the middle of Washington, D.C. And we have basically all of the paintings are going to go from a stage 1 to stage 7 with different sub-stages. So there are like 32 different stories.
Wow. When is this? When is it going to be?
This is going to be the whole month of May. So it's, and the way DuPont Underground runs, it's Friday, Saturday, Sundays, because Washington, D.C. has so many museums. So, the galleries and exhibitions have difficulty competing with them, and everything is free, by the way. So the exhibit space is open from like 11 to 5 every day. And it's the whole month of May. The first weekend, there is like on Friday, there's a reception and there's a talk. There's an artist talk that I'll be giving. And then I think the very last weekend, there's a book that goes along with it. Like there's an art book. It's pretty much like a coffee table book. It's very expensive. Don't buy it. It's like I'm just producing it. It's like my wife is like, "You're spending so much money on this book." I'm like, "It's an art book. What do you expect to do?" But for those of you who have extra cash to buy the book, I will be signing it off for them, like at the end of the exhibition.
That's amazing. That's amazing.
But again, the point of it is really just advocacy for the problem, so people know that this exists. So even if you cannot come to see it in person, these are just really amazing paintings. I've been painting all my life, but these are just each of them tell a story. Even if you can't come and see them, go and subscribe to like Shobeiri Art and share. Once I put the story out there, share it with your friends, because this is just it's not just about Shobeiri's art. It's about the fact that people are suffering and they have injuries, and like Kim said, we just need so much more stress on this issue, and education and awareness, and really literally all hands on deck to make sure that this just doesn't stay a normal.
Yeah. I can't wait. I didn't know this about you, and I am so excited. I absolutely love art. I do my own art sort of just a little bit on the side, and I hope one day to have a gallery, but it actually will be nothing pelvic health related, I don't think. But but I'm really excited to see that, and I hope that people will come and see you. So huge thank you to you for your time, for the work that you do, for the people that you are helping. You really truly are transforming lives where hope really didn't exist for so long. And I also the work you're doing to train others so that we can get this around the world, because there's injuries all over. So thank you so much.
And Kim, I want to thank you for what you do. I know there are a lot of things that you could do besides being a vagina coach, but this is your passion. And this is really very important. I mean, just the fact that you are using the word vagina publicly, right and down there or down below or something, it's just another body part that people have, and it's very important body part that has very important functions that we don't talk about. Peeing, pooping, sex, orgasm, these are just functions that we take for granted, and when they don't work anymore, you're just miserable. So just having a vagina coach in this world is amazing. Thank you.
I appreciate that. Thank you so much. Thank you. Super grateful for this conversation.
Thank you.